Hey folks, Eric back with you with FlightBridgeED. We're going to start on podcast number 3 of the Dominating Acid-Base Balance podcast series that we started. So in part 3, we're going to really look at the winner's formula. We're going to try to figure out and understand how we can affect change with our pH. Remember, pH drives everything. It drives homeostasis. It is affected by a lot of things. It's affected by strong acids, weak acids. It's affected by excess CO2. It's affected by excess bicarb or not enough bicarb. And it's also affected by acids such as sodium and chloride and other things like potassium. So we're going to talk about those different aspects. In podcast number 1, we looked at understanding acid-base balance, reading a blood gas, figuring out a good approach, and we looked at the values and we kind of applied all those things. In podcast number 2, we looked at strong acids and weak acids. We looked at sodium and chloride, and we looked at potassium. We looked at albumin. We corrected for those things, and we tried to account for base deficit. We tried to figure out where the different acids were coming from so we can make corrections to our blood gas and try to treat our patient. And in podcast number 3, again, we're going to look at the winner's formula. So how can we apply change in our blood gas, right? We go in on a transfer, we have an ICU patient, we get a blood gas, we decipher it, and we decide that they're in a pretty severe metabolic acidosis. Can we make a change in their clinical course in the time period we have of that patient? And I argue that we can. We really can make a difference. We just need to apply some strategies. So let's first kind of break down different aspects. Obviously, in our blood gas, we have a pH, right? And what we're trying to do is we're trying to affect pH positively and to bring it back to as close to or as perfect of a pH of 7.4 as possible. That's our goal. We may not get there, but we need to start driving that pH towards that point, whether you're acidotic or you're alkalotic. One of the quickest ways to do that is by affecting PaCO2. We know PaCO2 is important because when PaCO2 increases, we have an increased amount of hydrogen ions, and an increased amount of hydrogen ions basically causes the carbonic buffering system to kick in, right? We have excess CO2. We learned about this. We learned that when you have the CO2, that buffering system turns that CO2 to carbonic acid and then turns that into bicarbonate. And so the way to think about this, for every 10 millimeters of mercury we change PaCO2, it will cause a 0.08 increase or decrease of our pH in the opposite direction. All right, so what does that mean? So let's say we have a pH of 7.10 and we have a PaCO2 of 60. If we ventilate our patient a little bit quicker, and what I mean by that, if we increase the minute ventilation up a little bit more, and we try to maintain an end-tidal CO2, because remember, your end-tidal CO2 is never going to be less than your PaCO2. It's always going to be equal to. It may not be, it'll never be more than that, but it's never going to be less. All right, so it's going to be very close to your actual PaCO2 most of the time. So you can use your end-tidal CO2 in this situation to kind of guide you to change your pH to a normal value. So you start out at a 60. We need to try to bring that down 10 points. Remember, the rule is 10 millimeters of mercury decrease in PaCO2 will cause the pH to increase in the opposite direction, right, towards each other. So they're going to go towards each other by 0.08. All right, so if we have a pH that we start out at 7.10 and we decrease our end-tidal CO2 to 50, so we've dropped it 10 points, that means we're going to have an increase in pH to 7.18. All right, you guys see that? Let's try it in the opposite direction. Let's say you have a pH of 7.10 and you hypoventilate your patient. You don't have adequate minute ventilation, and your end-tidal CO2 increases by 10 points, right? Well, your pH is going to go the opposite direction, right? So if we have an increase in PaCO2, we have more acid, and with more acid, we're going to cause a more acidic pH. And so with that 10-point increase, we're going to drop our pH by 0.08. So a 7.0 pH would now be 7.02. All right, so that's a really important concept to understand, especially when you're talking about maybe a DKA or aspirin overdose patient where their pH is very critically low in the first place, and we've determined we need to intubate them. The big aspect of that is we don't want a big precipitous drop in pH because that's going to lead to arrhythmias and bradyarrest and will kill our patients. So that's very important to see that just a 10-point increase in PaCO2 has a big direct effect on pH in the opposite direction. All right? Everybody understand that? Okay, so the next thing we can affect change on is your bicarbonate. Remember, bicarb is a base, right? It's a negatively charged ion. And so for every change in bicarb of 10 milliequivalents, the pH will change 0.15 in the same direction. Okay? So if, let's say, you increase your bicarb 10 points, your pH is going to increase by 0.15. All right, so let's apply that. You have a pH of 7.10, and we have a bicarb of 15. All right, so that's going to be a metabolic acidosis, right? We don't have enough base. We have too many acids, so our bicarb is low, right? So we have a 7.10 pH. We have a bicarb of 15. So let's say based on things that we're doing to the kidney, whatever we're doing metabolically, we increase our bicarb from 15 to 25. All right, so we've increased it by 10 milliequivalents. That's going to have a huge impact on pH. This is probably the biggest thing that's going to impact pH. So we're going to go from a 7.10 to 7.25, right? So if we increase bicarb a little bit more, you can see that we're getting into that normal range of pH very quickly. So whatever we can do to affect bicarb positively, that's really going to have a huge correlation, a huge effect on pH in the positive direction. All right, so then we have potassium. Potassium is the most prominent extracellular ion we have. All right, it's very important for many aspects. We got the sodium potassium pump. It's essential for muscle firing. It's essential for the action potential. I mean, it's a very important thing. All right, so the thing about potassium, though, is we talked about this in podcast number 2. When you start having an acidosis, we have increased hydrogen ions. Remember, you have an abundance of hydrogen ions. Your body's always going to produce hydrogen ions to help compensate for things. Well, the bad part about that is hydrogen ions are more dominant, and so they go into the cell, and there's not enough room, and it pushes the potassium out of the cell. That's where we get a false high. When you check a blood gas or you check a labs on a patient in metabolic acidosis, most often you're going to see a hyperkalemic state. You're going to see a potassium that's high. All right, so what do we do about that? Well, remember, this doesn't mean that they have an abundance of potassium. It doesn't mean they have too much potassium all of a sudden. It just means the potassium's in the wrong place. And it's important to understand that we need to correct this, but we need to correct it in the right way. All right. All right. So let me see if I can explain this a little bit more. So you have hydrogen ions. As the hydrogen ions increase, the increased hydrogen ions overtake the cell and kick out the potassium. It now has a positively charged cell. All right, because hydrogen is a positively charged element. As your pH drops and your hydrogen increases even more, your potassium increases and floods the bloodstream. So that's where you have this increased potassium level that's in your blood. All right. So what's the relation between potassium and pH? What's the relationship between pH and potassium? Okay. So for every change in pH of 0.1, we see a potassium change increase of 0.6 or decrease as it relates to pH in the opposite direction. So it's always going to go in the opposite direction. It's kind of similar to PaCO2. The change is always going to be the opposite direction. All right, so let's try a couple. You have a pH of 7.0 and you have a potassium of 6.0. And we start correcting the metabolic acidosis. Remember, this is a false high. This number that you're seeing on the lab isn't true. It's not that you have an abundance of potassium. It's just in the wrong spot. So by correcting the pH in theory, you're going to start pushing that potassium back into the cell, right? Because we'll have a removal of hydrogen ions. It's going to make room in the cell for the potassium, and the potassium is going to go back where it belongs. All right? So by correcting the metabolic acidosis, just in theory, the potassium is going to correct itself. So you have a pH of 7.10, and you have a potassium of 6.0. Okay? Remember, if you have a change in pH of 0.10, you're going to have a potassium change of 0.6, right, in the opposite direction. So we're going to increase our pH from 7.10 to 7.20 based on whatever maneuvers we may do. Maybe we're affecting PaCO2, maybe we're affecting bicarb. So this is kind of happening behind the scenes. So your potassium is going to drop. It's going to go from 6.0, it's down to 5.4, right, because we had a 0.6 drop in the opposite direction. So if we increase pH, our potassium is going to drop. So if we apply this, we can really make a change in our potassium. Let's try another one. So let's say we don't affect change, and let's say we continue down a omnious path of metabolic acidosis and our pH is 7.10. We're not treating our patients appropriately, or for that matter, they're just so sick that we can't get ahead of their metabolic derangement, and their pH drops from 7.10 and now it's 7.0. Okay, remember, if you have a 0.1 increase or decrease, we're going to have a increase or decrease in the opposite direction of the potassium of 0.6. So if our potassium starts at 6.0, it's now going to increase to 6.6. You guys see that? I'll say that again. We start with a pH of 7.10. We decrease our pH to 7.0, right? So we have a 0.10 decrease. And so that's going to make the potassium increase from 6.0 to 6.6, right? So our potassium is getting worse. We're getting increased hydrogen ions that's flooding that cell. It's pushing the potassium back out, right? So our serum blood level of potassium is increasing, all right? The other aspect is this. So for every change in PaCO2 of 10, we see a change in potassium of 0.5. So there's two aspects here. We can have a change in pH, and we can have a change in CO2. Why does CO2 affect potassium? Okay, it goes back to that carbonic buffering system. It goes back to that increased hydrogen ions. We know if you have increased CO2, you're always going to have an increase in hydrogen ions. That's just automatic. Always remember that. They go side by side. So if we have an abundance, if our CO2 increases, we're going to have increased hydrogen ions. That's going to push into the cell. It's going to push the potassium out. So the same goes for that. If you have a big increase in PaCO2 of 10 points, you're going to see your potassium increase by 0.5. All right. So if you, let's say you start out and your PaCO2 is 50, and for whatever reason it increases to 60, and your potassium starts at 6.0, just by increasing that PaCO2 or maybe not managing the minute ventilation appropriately, you're going to drive that potassium up to 6.5. Okay. So that's an important aspect to understand. All of this is related. All of this correlation. Hydrogen drives everything. CO2 drives everything. And it affects a lot of things. It affects pH. It affects potassium. Okay? So does the patient have too much potassium when they're acidotic? No, they do not. They have the potassium in the wrong spot. Remember, it's not in the cell where it belongs. It's out in the bloodstream. So does this affect the heart? Well, absolutely it does. And your heart doesn't like this. And so this can cause arrhythmias. It can cause hyperacute T waves. It can cause MIs. It can cause a lot of problems. So we need to watch our patients. We need to do a 12 lead on them. And we need to manage this. The other aspect I want to talk about, and I talked about this in podcast, I believe number 1 and number 2 is remember in a DKA patient, where in a DKA patient we have this massive fluid loss. We're peeing out all this urine, and with that goes potassium. So we're getting rid of all this potassium. So in a DKA patient, it's very important, even though they're in a metabolic acidosis, we've got to look at the potassium, and it's going to be low most of the time. And that's where we have to treat that. And we talked about that in podcast number 2. We talked about the dosing of how to treat that. But it's very, very, very important to understand and to identify very quickly on in this process because what are we going to do to treat DKA? We're going to increase their fluid. We're going to start giving them volumes of fluid. That's going to wash out the potassium even more. You're going to start correcting the metabolic derangements, which is going to do what? It's going to make the potassium go down, right? If we increase our pH, by 0.1, we drive potassium down by 0.6. So remember, our whole point in this whole process is to correct the metabolic derangement. But it's going to affect the potassium in a negative way. And if you're already low on your potassium, we've got to correct for that. We have to start giving them potassium with their fluid, or you're going to kill them. I mean, essentially. All right. So remember, though, you can't, in a hypokalemic state, we can't correct this fast enough. So we don't want to get to the point where we're behind the 8 ball. We've got to treat this aggressively. All right, so how do we treat a high potassium, right? And we talked about if you had a severe metabolic acidosis and you had extremely high potassium, how are we going to treat this? Well, let's talk about that. So remember, our whole point of this whole thing is we've got to push that potassium back in the cell. We've got to correct the metabolic derangement, which is going to correct it, but sometimes that doesn't work. So we've got to correct that. And so the first thing we do is we want to correct the metabolic problem and see if that changes the pH. Sometimes it won't. Sometimes it may be that they have true hyperkalemia, and we've got to correct that, or your heart's not going to like that. So here's kind of the whole adage of how this works. Is obviously we want to give insulin. Insulin is important. It's a carrier, and it's a carrier for the D50. So this is how we kind of play this. First thing you're going to do is you're going to give calcium chloride. Calcium chloride raises the action potential threshold, and it helps drive the potassium into the cell. All right. We're going to give sodium bicarb. This in turn raises the pH. It also increases the electrical gradient, and which helps with the action potential. Okay. Sodium bicarb raises the pH, right? Because it's a buffering system. It's a base. We have too many acids. The bicarb is going to raise the pH from an acidic state. So we know that if it raises the pH by 0.10, we're going to drop our potassium by 0.6 in the opposite direction. Okay? So that's one way. The other aspect is we need to give sugar. Sugar is it needs to be transported into the cell, though, and that's why we always piggyback this with insulin. And what the sugar does is it causes the potassium to shift with that movement. So the potassium needs a carrier also, and it attaches to that glucose molecule, and it drives it back into the cell. The insulin moves the dextrose molecule across the membrane. It's a carrier, and it carries that glucose molecule that has the potassium hooked onto it, and it shifts it back to the cell. So all of these things kind of work side by side. You've got to use all of them to make this work. We know albuterol is used in other settings as it relates to asthma, COPD, to open up the upper airways, and it's a beta-2 agonist. But as it relates to hyperkalemia, what it does is it causes a beta stimulus, and basically it allows it's a carrier as well, and the potassium attaches to it, and it's able to cross that membrane back in the cell. So we have 5 different things that we give that all work hand in hand as carriers, as transporters to drive that potassium back in the cell. We're going to try to first correct the metabolic derangement. Second thing we're going to do if the potassium's still high is we're going to start treating the potassium. We need to make sure the potassium doesn't correct itself, though, with a metabolic problem. If we correct the metabolic problem, we're going to give calcium. If that doesn't work, we're going to start with there. We're going to give an amp of calcium chloride. We're going to go and we're going to give the sodium bicarb. We're going to give the insulin and the D50, and we're going to give the albuterol. And all of those things intertwined are going to work. So how much do we give? Well, we can give 1 to 2 amps of calcium chloride. If you don't have calcium chloride, then you can give calcium gluconate. But remember, there's a difference between calcium chloride and calcium gluconate. Calcium chloride is concentrated. So for 1 amp of calcium chloride, that equals 3 amps of calcium gluconate. And so the big thing with the two is in the EMS realm, maybe on the helicopter, we're going to probably use calcium gluconate because you can give it IV. It's not going to cause a big of a problem. It's got the gluconate aspect, the sugar molecule attached to it, so it's easier as far as a transport carrier. Whereas calcium chloride is going to be more of a severe case where you're going to want something to work very quickly. It's preferable to use a central line in that situation to push that, because if it extravagates out of the IV, it'll cause tissue necrosis. D50, you're going to give an amp of D50. And 1 amp of D50 is equal to about 5 to 10 units of insulin. So you have to always make sure, again, you give the insulin, because the insulin is going to be the carrier molecule to transport that D50 across the membrane, the cell membrane. And then albuterol, you're going to have to give a pretty big dose, and I believe it's about 5 milligrams nebulized. And again, the potassium attaches to that beta receptor, and the beta receptor can cross over into that cell very easily. All right, so let's do a few problems real quick, and then we're gonna be done. So let's start off. We got a pH of 7.22. We got a PaCO2 of 35. We have a bicarb of 14, and we have a PaO2 of 90. All right. So what are we gonna do? What should your end-tidal CO2 read when the pH has been corrected to 7.38? All right. So we have a PaCO2 of 35. We want to try to increase that pH. So remember, if we ventilate our patients quicker and we drop our end-tidal CO2, all right. So let's say your end-tidal CO2 on this patient is 44. So it's going to be a pretty close correlation to our PaCO2. And we need to hyperventilate this patient to try to drive up the pH. Okay? So what we're going to do is we're going to start off with an end-tidal CO of 40. Well, let's say 42. Let's say 42. We'll make it easier math. So we'll start off with an end-tidal CO2 of 42. We're going to decrease that end-tidal CO2 to 32. So what's that going to do to our pH? Well, remember, it's going to increase our pH by 0.08. So our pH starts at 7.22, and it's now going to increase to 7.30. If we bring our end-tidal CO2 down another 10 points, it's going to, again, have another increase of 0.08. So really quickly, by affecting our end-tidal CO2 by 20 points, we've increased our pH from 7.22, which is an acidotic pH, up to 7.38, and we're getting very close to a normal pH. All right, so let's do one more. What will the potassium become when the pH adjusts to 7.42 on the same patient? So on the same patient, let's look at some labs. We have a sodium of 135, we have a potassium of 3.8, and we have a chloride of 87. So what is our SID? Well, our SID is way out of whack here. We have a sodium of 135 and a chloride of 87, and so that's going to be a SID of 48. And so we have, in that situation, we don't have enough chloride. All right, so that's easily fixed. As far as this patient goes, what's our potassium? Our potassium is 3.8. So how are we going to affect our potassium? What's going to happen to our potassium if we increase our pH? So the same patient, we're going to start with a pH of 7.22. We're going to increase our pH based on whatever we do with our bicarb or our PaCO2, and let's just say our pH increases to 7.32. Remember, an increase of 0.10 in our pH is going to have the opposite effect on our potassium in the opposite direction by 0.6. All right, so if we increase our pH from 7.22 to 7.32, and our potassium starts at 3.8, we're going to decrease our potassium to 3.2. All right, if we want to get a pH to 7.42, right, and that's as close to normal as possible, remember everything is driven off pH, then our potassium is going to drop again by 0.6, and it's going to be now 2.6. So what do? Well, that's a critical low. So we need to kind of foresee this. We need to look at our potassium, we need to look at our pH, we need to look and foresee what the clinical course is going to entail, and we need to start treating that potassium way before we get to that point. So if we know we're going to affect pH by affecting ventilation or affecting things by bicarb, then we need to start treating the potassium early on. So that's very, very important. Remember, hypokalemia is a bad thing. We can't fix it quick enough, and we need to account for it. So that's all I have as far as podcast number 3 for this dominating acid-base balance. I hope you guys got a lot out of this. I know there's a lot of information. I will put all these aspects and notes in the podcast forums, documents, attachments, so you can refer to them. If you have any questions on this stuff, please email me at eric@flightbridge.com, and I would love to talk to you about it. And we thank you so much for your support, and we'll talk to you soon.